this session is really just a question and answer session. And so it looks like we're down another panelist. So maybe she'll arrive in a bit as well. But that's fine. We are very well represented with Dr. Divi and Dr. Gensheimer. So many of you may know these two gentlemen. Dr. Divi is a head and neck surgeon who is part of our group, and Dr. Gensheimer is a radiation oncologist who's part of our group. So they are happy to answer questions that you may have about anything. That now's the time you get to ask all of your crazy questions. Make sure you really make it hard on them. Make them earn their keep here. All right, so we've got a question from Ron in the front.
Hi there. This is a question for the radiologist. My problem was base of tongue, and I want to know, as far as the radiation map goes, how my brainstem was protected, the substantia nigra, and just that area. Because radiation goes through you, right? It doesn't just stop. I mean, it goes all the way through. So I'm concerned about how that area was protected when I had my radiation for that location, base of tongue. Thank you.
Yeah, sure. You bet. Yeah, thank you for the question. Nice to see everybody. So yeah, very glad to be here. Okay, let's see. So I don't know the exact radiation that was plan that was used for you, so I can't give you the specific answer, but I can answer in general if I were treating a patient with a base of tongue cancer. So we use a fancier kind of radiation called intensity modulated radiation therapy to protect the normal structures around our targets. The head and neck is a very challenging area to do radiation in because you have this area we need to treat to a pretty high radiation dose to cure the cancer, nestled among all these really important things for your speech and swallowing and thinking and all these different things. So the brainstem, luckily, is not that close to the base of tongue, so it's not far away either. But we use the intensity modulated radiation therapy to avoid it, and so it's very rare to have any brainstem damage. So with the intensity modulated radiation therapy, the machine is rotating around in a continuous arc around you, kind of in this direction, and delivering treatment to different parts of the tumor from different directions. So we carefully delineate out the brainstem and the spinal cord, which is right below it. And when the machine's behind you, it's delivering very little dose to the middle part of the tumor because we're specifically trying to avoid your brainstem. When it's to the side of the tumor, then it delivers a lot of dose into the tumor because the brainstem and spinal cord are in the way. And so we're able to shield those very nicely. As any survivor of head and neck cancer and radiation knows, we're not able to completely eliminate toxicity. And of course, we're working all the time to try to reduce that. Thanks for the question.
So you're saying that the brainstem really isn't at risk in this. You're saying that the location is not really where the beam is going.
It's not that close. Yeah. We're able to be pretty pinpoint with the treatment. So it's a few centimeters away, which is plenty of distance for us to get a nice fall off. When we're treating cancers in the nasopharynx in the back of the nose, sometimes those cancers invade into the base of the skull area right next to the brainstem, and that can be when things get a lot more tricky. And then all the details really matter in that case. It's very fine margins, and so we use really high-quality MRIs to try to delineate the edge of the tumor and the edge of the brainstem, and we get a little bit fancier with it, and we maybe our blood pressure rises a little bit more as we're trying to find that balance, but not as much for base of tongue cancers.
Thank you for your help.
Thanks. Sorry, a related question. So, as principal investigator for a trial examining the use of high-dose radiation therapy to increase response to immunotherapy for patients, have you been working with Dr. Monge in terms of the understanding all the, what I want to call it, side effects related to cognitive impairment downstream? And is the increase in immunotherapy effectivity possible to increase the, let's call it, downstream side effects in terms of cognition and things like that?
Oh, yeah. Well, Dr. Divi also has some trials with immunotherapy, so he might have some thoughts about this one, too. Yeah, nice to see you, and a good question. Well, yeah, so let's see. So, yeah, we've done some clinical trials combining radiation therapy and immunotherapy, things like pembrolizumab and nivolumab. That specific trial that you're mentioning was in lung cancer that we did, and we saw some really promising responses in people with metastatic lung cancer that had spread all across the body. We did not see cognitive issues in those patients who were on our trial, thankfully, but their radiation was generally in the chest, far from the brain. So yeah, if you combined immunotherapy and radiation close to the brain, like for head and neck cancer or for a brain cancer, yeah, you'd have to carefully study the cognitive effects. Luckily, I wouldn't say that cognitive issues are a main side effect of the immunotherapy. I mean, once in a while, someone maybe could get like an encephalopathy kind of autoimmune condition, but I haven't seen a lot of that. I don't know, Dr. Divi, if you've seen that in your trials.
Yeah, I haven't seen. There are some rare side effects that can happen, but they're extremely rare, more on a case report level of having some brain-related inflammation. And then generally for the trials that we've been doing, the radiation and immunotherapy are given at two separate times. So we've been giving immunotherapy before surgery, and then in the adjuvant setting, so after treatment, usually they'll get their radiation completed and then they'll get immunotherapy. So, even though there's potentially still some on board, when they're getting their radiation, the dose would be actually pretty small.
Just to bring a little bit more context. So we had a speaker this morning who was talking about the more subtle effects. So definitely nothing to the level of like encephalopathy, but maybe more long-term issues around memory, attention, those sorts of things, and how there's some evidence showing that both immunotherapy and chemotherapy have similar effects, sort of at a cellular level, that can impact those drivers of cognition. So I don't know whether I haven't seen anything specifically looking at those outcomes or endpoints in head and neck with any of these immunotherapy trials.
Yeah, it's pretty rare. Even when we consent people, it's not, we usually try to bring up all the major, either things that are very rare but very concerning, or pretty frequent and less concerning. And that isn't usually on the big list of things that we talk about.
But anybody who's been on our clinical trials and has had to fill out a big mountain of questionnaires and different things, that's why we have you do those, because we want to learn about these common and rare effects of the treatment. So thank you for filling out all those questionnaires.
I have a couple questions. I had stage 4 nasopharyngeal cancer, 2012 to 2013, so it's been a while. And the main damage are what I'm still currently dealing with. One is the dental, and I was kind of curious at the time when I started the treatment, I had to have all the main chewing tube pulled off, and then I was not qualified for dental implant. And then now 10 years passed by. I'm curious in terms of radiation damage, like, does it go less? Say now 10 years passed by, maybe I've qualified for dental implant, maybe not. I don't know from a radiation exposure perspective. And I have probably some of the highest dosage a human body can take, given I was stage 4. And I unfortunately gone through the most traditional treatment. So it was a combination of chemo and radiation, 33 set of radiation plus radiation surgery. Yeah. So what are some of the potential?
Yeah, that's a great question. And yeah, that is one of the most challenging things for sure, is this the dental issues. So unfortunately, the damage to the bones, especially the jawbone or mandible bone, they don't really repair themselves so much after radiation. So some radiation side effects like taste changes and dry mouth, as you know, they get really bad toward the end of the treatment and gradually get better over the next 1 to 2 years. But unfortunately, the decreased blood supply to the bones and scar tissue in the bones can continue gradually building up even for many years, even decades. So no, I wouldn't say that the blood supply has probably rebounded that much, and it would probably still be an issue to get the implants. Again, same caveat as the other question. I'd have to look at the details of your radiation plan and all that, because at the same time, there's always a risk-benefit calculation. There will be a risk of osteoradionecrosis if you get the dental implants, which can be a really big problem if it happens. And again, I'm going to ask Dr. Divi his perspective on this, because he's the one who has to help repair that if that happens. But some, I would say the historical studies from decades ago showed a very, very high risk of osteoradionecrosis with tooth extractions or implants after radiation. Some of the more recent trials have shown a lower risk. So there was a clinical trial from the United Kingdom called the HOPON trial, HOPON. And, they saw a fairly low risk of ORN or osteoradionecrosis. So it depends on the exact situation. But no, in general, the simple answer is there's not that much recovery of the bone over time.
Okay. And my other question is, I recently has a lot of spinal numbness and pain. And then their MRI scan shows that I have severe damage between C5 and C6. And then those are cervical spines right in the middle. And I know, given my cancer was metastasized to 4, 5, 6 nerves, and then also some nodules here. So this whole area was being heavily radiated. And I'm always curious that if potentially my cervical spine could have been suffering from some of these radiation exposure as well. Is that possible?
Yes, that is very possible. You guys are asking really good questions, and some of it I'm having to dodge a little bit because I would need to know more details, which probably is not appropriate to go through into the details right now. But sure, I mean, if the cancer was right next to the cervical spine, then generally if we're trying to cure the cancer, which we are in many of these cases, we're going to be pretty aggressive there, and because we know if we don't cure the cancer, then we're not going to have to worry so much about the normal tissue late toxicities. So yeah, they may have treated the spinal cord to a fairly high dose, and that certainly could cause some long-term issues. But it's a little bit hard to say without more details. The radiation can also damage the nerves that are coming out of the spine on either side. So you have exiting nerve roots on either side that supply sensation to the skin and other areas. And so those are often closer to the high-dose radiation than the spinal cord itself.
Okay. And then another one, this might be a little trickier. So given the cancer metastasized to 2 muscle nerves, right? So I recently was also diagnosed with fatty liver, which not normal for my body weight. And the main challenge the gastro-oncologist told me is that basically my muscle is not moving, like not moving normally. And which I was curious, could that be because the damage for my nerve muscle might have caused, I don't know, the stomach muscle that not moving properly?
Oh, I see. Okay. Yeah. Interesting. It's kind of like Dr. Divi said. I mean, there can be rare side effects, many, very, very rare things, but I have not seen someone with problems with their bowel motility, like the movement of things through the bowels from head and neck radiation. So that may be a separate issue. Though again, I hesitate to ever say it couldn't be possible because we can, in a rare case, cause all sorts of rare issues. But I'm not seeing the connection right now. And maybe Heather or Dr. Divi can think of something else. Something to talk to your doctor about, I think.
Okay. And my last question is, are you aware of any clinical trial supporting head and neck cancer patient with saliva gland recovery? My saliva gland not only damaged due to radiation, I also have Sjogren's syndrome, which is kind of like a double whammy. It's my immune system also attacking. And that's been one of the biggest struggles that I have. So I think at one point I saw there were some clinical trials, like trying to use immunotherapy to support potentially treating saliva gland damage. I'm not up to date with that. I'm just kind of curious if you guys are aware of any.
Yeah, I don't think we have a trial open right now. I know I remember someone was bringing some potential clinical trials to our group last year about this, like once the salivary glands are already damaged from the radiation, trying to bring the function back. I know there are some new medications being tried. I don't think we have that clinical trial open right now. So there are various different things being tried. I don't think we have a clinical trial open here right now for that. We are very interested in preventing the damage in the first place, which wouldn't help you, but would help future patients. And so we have a clinical trial open. It's called our D-limonene trial with one of my colleagues, Dr. Quinn Lee, the chair of my department. She has a laboratory, and they have this promising supplement called D-limonene that we're testing to try to reduce the salivary issues. And then, of course, we're getting better and better with our fancy radiation machines, avoiding the salivary glands. So we're trying to prevent it in the first place. But yeah, I know there are definitely some different things with stem cells and different things people are trying. But with all these things, you got to test it rigorously in the clinical studies, because there are a lot of things that sound really appealing and work great in a mouse. Then you try it in people and it doesn't work as well. I know I hear your impatience. You want it to get improved, and I'm totally with you. But unfortunately, it takes some time. But we're working on it.
Could you describe any recovery from neuropathy due to radiation? Is there any opportunities for interventions to improve, say, a far extremity like your feet or something like that?
Well, neuropathy after head and neck cancer treatment can be from multiple causes. So radiation could certainly cause neuropathy, most commonly from damage to the brachial plexus that goes to the arms. But the chemotherapy like cisplatin and carboplatin and paclitaxel can cause neuropathy. So sometimes it's from the chemo. I'm not really an expert in recovery from neuropathy. I know that if patients suffer a brachial plexus injury, I will refer them. We have subspecialty neurologists here who see the patients and help with that. But it can be a challenging one because there's kind of this damage to the nerves, and so you can do physical therapy and different things, and there are medications to reduce pain, but it can be difficult to address the root cause of it.
As a follow-up, radiation affected the nerves, I presume, in this portion of my body, and so I have a permanent bit of a slump, and physical therapy has, done what they can relative to strengthening. But the question that I had, is there any other interventions that you're aware of?
Yeah, so for the shoulder slump, that could be from radiation. So let's see, I already blamed chemotherapy for neuropathy. So now I'm going to turn to Dr. Divi and point out that a shoulder weakness after surgery plus radiation is actually often more due to the neck dissection surgery. I don't know what treatment exactly you had. So there can be, again, sort of various causes of these issues. So Heather, maybe I'll turn to you. I mean, you're an expert in rehabilitation and these things. I think physical therapy would be the mainstay there, but I don't know if you have other comments.
Yeah, no, I think physical therapy, but I think one of the things we know about a lot of the damage that happens with head and neck treatment is that time is of the essence. And so if we've got a problem that's been there for 10 years, it's less likely to respond to therapy versus something that is a newer issue. So we always advocate for early intervention whenever possible and getting these things worked on as close as possible to the time, because as we get into 5 years, 10 years out, the treatments are not as effective. But I would say physical therapy is definitely the primary thing that you'd want to be doing for that.
Yeah, initially after surgery, people can have a temporary paresis. I liken it to how sometimes you fall asleep on your arm and you wake up and you can't move it for a couple minutes, a minute. But you can have the similar thing just from surgery, but that can actually last 6 to 9 months. So you can actually have a delay. But then if you continue to be weak after the 9 months, then it could either be a surgical related issue or further treatment related issue that wouldn't automatically get better and may plateau out where you are at about a year.
Yeah, most of the injuries that are nerve-related injuries are really tricky. We don't have good treatments for those. So any of the neuropathies, some of the late swallowing issues that are related to nerve injury, shoulder function, if it's nerve, we don't have great treatments. But there are a lot of really, really smart people trying to figure out if there's something we can do.
As a willing potential test rat, do you guys do clinical trials for patients at certain buckets of stage, like long play trials over time? I know the mortality rates of studies are such, 3 to 5, what have you. Do you do something like, so I'm 16 months in, is there like any worth of, am I have any value for clinical trialing going forward? I mean, is there a point that after 5 years, let's go ahead and circle back to these patients, or is it mostly while in treatment or just before procedure? How does clinical trials work, again, as a willing potential test rat, with all due respect to test rats?
Yeah, so they're always driven by clinical questions. So the question would be, for example, in your case, you're outside of treatment. If you were high risk of recurrence, we may ask for, we might try to put together a trial as how do we take people we know are at high risk for recurrence and decrease that risk. If you're low risk of recurrence, we might be focused more on survivorship and questions around rehabilitation. So first, it'll always be driven by a question. In the setting of someone who's finished their cancer treatment, most of the trials we have targeted are around if you were to recur, how would we then proceed with treatment from there? And Heather can probably speak to about clinical trials in the rehabilitation setting, survivorship setting, and there's certainly a lot of work to be done there. Generally, that would start off closer to when you finish treatment, but how do we kind of test what interventions in the long term are actually be beneficial to people?
Yeah, there is a resource called clinicaltrials.gov, which is a national database of all kinds of different clinical trials. So you could always go on there to see if there's something that sort of you fit the niche for. But you're right, absolutely. Most of the things are done a little closer to, unless there's a major problem. Like, for instance, there's a clinical trial being done at UC Davis and UC San Francisco for survivors of head and neck cancer with really significant swallowing problems. So if you were somebody who had really significant swallowing problems, that might be something that would be an option. Thankfully that you're not in that category. And there, I know there's another clinical trial ongoing right now for both patients with head and neck cancer and caregivers of patients with head and neck cancer on sort of mindfulness stuff around dysphagia. So there are things around that. I don't think we have anything for sort of later survivors currently, but that doesn't mean we won't in the future. So, we'll told you again once we have something appropriate for you.
Yeah, we're always talking to our colleagues about these things. There's a guy, a surgeon, Dr. Evan Grabois is his name. So you might want to just look him up. He's running a lot of clinical trials. He's not at Stanford, but a lot of clinical trials involving survivorship and what happens after the treatment long term. So Evan Grabois is his name. And so you might have some interesting resources.
I have just a general non-technical question. Are you seeing an increase or decrease in oropharyngeal cancer related to HPV? I don't really follow the statistics, but I don't know if it's still increasing or it's decreasing or it's about the same. Is any feel for where this stands?
Yeah, it has been increasing for several, over a decade that we've seen it. The current trajectory, I'm not sure I know exactly like where on the slope, but I do believe we are still in an increasing trend. I think we'll continue to be on that trend until the vaccination that kind of started about 10 years ago starts to catch up and we'd have an increasing population, but there will be a exposed cohort that probably for the next 20 to 30 years will continue to develop that.
It's a little scary, isn't it? I mean, how can you detect? I mean, the whole idea is you got to detect this stuff early and not get it when it's advanced. And it's hard to detect when it's early. So how do you get the word out that, there's this increasing trend of HPV or pharyngeal cancer, and how to make people aware of it that are, a high-risk group or whatever?
So one of the things, I'll just comment quickly, because there is actually currently the HPV Cancers Act that's going through Congress. So we are starting to get a little bit of positive, energy behind this. We're still at only about 60% of youth being vaccinated in the U.S., so we still have a long way to go before we even get to that herd immunity that we're looking for. So I think not only are we still on an increasing trajectory, but unless we start getting the word out more, we're going to continue to be on that. So I think all of us have a role in getting the word out about this and getting our youth vaccinated.
Where did you say it's happening through Congress?
It's called the HPV Cancers Act. It's just going through Congress right now. Yeah, absolutely. If you, I can send out when we send the link for the recording for today. I'll send that out so people can look at it.
Is that something that Marcia Cross has been involved with?
Not that I'm aware of. No.
I know she's been.
Yeah, it's a lot of different organizations, a lot of advocacy organizations, so Head and Neck Cancer Alliance being one, but a lot of the gynecologic cancers as well. It's sort of everybody who has a stake in this.
It's great news. It made my day. Thank you.
Yeah, absolutely.
Yeah, and then in terms of cancer screening and all that, that's a whole topic. I mean, yeah, I think overall HPV oropharynx cancers are fairly rare compared to some other kinds of cancer like breast and prostate cancer. So your cost effectiveness of your screening program is going to go down. And then the other issue is you have to try to catch the cancer super early to make a big difference, but it's not so easy to catch these cancers super early. You could be doing physical exams on people every year, and it's a pretty big area you can develop these cancers in. You're probably not going to be doing scope exams on everybody all the time. So I think we also need better technology to make it easier, cheaper to look for these things early.
I'll throw a question to you guys. So I know last year Dr. Holsinger talked a little bit about HPV plasma DNA testing, and can you provide any insights on where we are on that? What are the thoughts? How is that being integrated?
Yeah, sure. No, that's definitely a hot topic. Yeah. So just to fill everybody in on the background, cancers in the throat, in the oropharynx, many times come from this virus called HPV that we've been talking about. And little bits of the cancer are always dying because cancers tend to outgrow their blood supply, and many parts of the cancer are dead. And so cells will break apart and deposit some of their DNA genetic material into the bloodstream. And so if you do a blood test, if you have active HPV oropharynx cancer, you can actually detect small amounts of the cancer cell DNA in the blood, which is really, really interesting. And it's really amazing how quickly this has gone from just more of a research thing in animals to research thing in people. And now there are clinically available tests for this. There's a commercially available test that we will sometimes order in our patients. So you order it sometimes before treatment, and then if it's positive before treatment, then after treatment, hopefully it'll become negative as you cure the cancer and the DNA goes away from the blood, and you can then use that test to monitor for recurrence of the cancer. So yeah, no, I find it very exciting. It's a little controversial because the question is always how quickly do you adopt these new technological advancements if you don't have great data that they improve the outcomes that really matter to us, which is your quality of life and your survival from the cancer and from other things. So these tests don't have data yet on improving survival rates from the cancer, but there are really accumulating information that they are really quite accurate. So this company called Naveris recently published a paper based on their results, and I forget the exact numbers, but the general idea is that if the DNA became detectable in the blood after treatment, there was an extraordinarily high chance that it was a real thing, that the cancer actually was back. It was, I think, 98% or some very high number. So really impressive numbers there. And many of us are starting to incorporate this into our practice. Oh, and the other nice thing about it is then we can reduce the number of scans we get because you can just do a blood test instead of having to do things like chest CT scans. So I like that part because there's less radiation exposure. And it's just a little more convenient for the patients.
Yeah, it's a really exciting space. I mean, right now there's not other tumors that we're really doing this for quite like HPV. There is the issue that some people get a positive test and their imaging doesn't show anything. So what do we, we're kind of waiting for the ball to drop in some of those situations. Some people are proposing trials where we'd actually start them on treatment to see whether or not that would actually decrease the chance of them having an ultimately getting a recurrence. In the skin cancer setting, which I end up, kind of do a lot of, the positivity rate's a lot lower. So it's only around 60-70% of patients who have any signal at all. And so it's not in every setting that it's going to be positive tests that you're going to be able to follow. So hopefully it's a space that'll continue to evolve, I think, over the next as we refine it. But it is pretty exciting that we can, the whole idea of diagnosing things by blood is a very evolving field.
It's amazing how fast things go from like sci-fi to something we're actually using every day. It just sort of slips up on you, and then all of a sudden you're just using this in practice, and oh yeah, so that's just what we do. It's very interesting.
Just to follow up on your comments about this, so if a patient came to you and said that they wished to have that test, what's the difference between the patient asking for it and receiving it versus the medical necessity of it and therefore being covered by insurance? it seems to me that if you try to advocate a treatment that isn't clearly medically necessary, then you end up getting kind of slapped back. So it's kind of this push-pull aspect of advocacy. I was just curious on your comment.
Yeah, that's right. No, yeah, and this is even in the news recently. The Grail-Galleri test, which looks to find various different cancer types early. That's gotten you see billboards for it now, but there are a lot of regulatory issues. And again, they've never shown that getting that test actually improves your chances of being alive or having good quality of life. So you can you could have different perspectives on it. For specifically in this situation with the DNA testing in the blood, one of the companies that we use, if your insurance does not pay for it, I believe that they do not charge you for it. So we don't want anybody getting stuck with a huge bill out of pocket unexpectedly. That's no fun, and that's stressful for everybody involved, and for your bank account. And so we there are some details that we work out, but with that can help with this issue.
Yeah, it is really an interesting space. I mean, there's a lot of other genetic tests, which Michael's also, I'm sure you're familiar with, in some of the other spaces. We see it in thyroid and melanoma and skin cancer, and companies sort of promoting tests that would then help us determine downstream how we treat things. And some settings are actually very useful, and some settings they're not. And it's kind of, I think it'll be evolving to see how those get incorporated. I think there's a push obviously by the companies for us to use all of these, but then there's a lot less clarity that they actually improve long-term outcomes.
Yeah, that's right. Yeah. It's something that we really wrestle with, because there's also I think doctors are now competing with each other a little bit on saying, well, if you come to me, I will order all these fancy things and we'll do these newfangled things. And it's really exciting. And sometimes that's really good, but yeah, not every new thing is actually going to help you, and some of it will just cause more anxiety as you're waiting to get the results. And so there are a lot of nuances to this, and we need to carefully study how much these things help.
All right, I'm going to ask each of you one final question, unless other people come up with questions. So, what is on the horizon? So we'll start with you, Dr. Divi. Surgical innovations. What are we seeing, and what are we thinking is coming on the horizon in the next decade?
Yeah, I think, what we've seen, I think, over the last decade, just kind of going backwards, is, I'd say on the removal side, the tumor removal side would be more minimally invasive approaches. So try to, whether it be robotics, endoscopic, or approaches that are less morbid in terms of accessing tumors. I'm not sure if we're hitting a plateau on that, but I think a lot of the technology, I mean, we've kind of, I don't think we're going to get much better optical things. The robots are going to continue to evolve, but it's going to be small stepwise improvements. So I think on the surgical side, it's, and something we talk about at Tumor Board all the time is how do we incorporate systemic therapy before surgery to think about how does that shrink tumors down? How do we then optimize, start off with a tumor, shrink it down, and then kind of do a smaller surgery from there. So I think that the physical resection of tumors may not change all that much. I think we've made a ton of progress on minimally invasive, a ton of progress on reconstruction. But I think now it's a little bit the question of what do we do before surgery, as long as surgery is still part of the equation, because there's going to be a lot of cases where it's no longer part of the equation. But how do we give either, there's some good studies showing giving radiation before, small doses of radiation before, immunotherapy before, that have shrunk things down and then made surgery either feasible in some settings or in some cases much less morbid than it would otherwise have been. So I think we have to refine those protocols. Head and neck is, one of the challenges. It's a small volume disease. So for us to do any study, it always takes a lot longer because it's just relatively rare compared to like a breast or colorectal. So we do take a little longer to kind of accumulate data and actually move the needle and change the standard of care, because I think there's a lot of institutions that are doing one-off kind of studies, and until we all kind of adopt it, it takes much bigger studies, which takes a lot longer.
Thank you. How about you, Michael? How about radiation approaches?
Yeah, great question. Okay, let's see. So I think there are multiple ways in which we will be advancing in the next 10 years. One is just the physical aspect of radiation, so getting to everybody's questions and concerns about all the normal tissues that we can damage with radiation. So we want to be more precise. We want to reduce the spillover effect into normal tissues. So things like different kinds of radiation, like particle therapy, proton therapy is very exciting and interesting. And we are helping to develop a new compact proton therapy system that, if all goes well, we may even be able to install within the Stanford hospital system. So that could be exciting. Then there's using radiation in a smarter way. So can we customize the amount of radiation better? Right now, it is rather simplistic, right? We have a kind of standard radiation amount for different broad situations. And we know that probably some of the people we treated, we probably didn't need to give that much. Some of them we should have given more. And it's very hard to tell until later. And so using things like scans halfway through treatment to see how the radiation's working and customizing the area or the amount that you give, I think we'll be figuring out more of that soon. And then finally is just improving the quality of practice, I think, is really important. So that's something that I care a lot about and something I've worked on. So this is things like using machine learning and artificial intelligence techniques to help doctors decide and patients decide what the best treatment would be for them. Again, maybe in a more customized fashion instead of a one-size-fits-all fashion. There's a lot of variation in medical practice. Some doctors are better, some are not doing as well, and a lot of that is really hidden currently, and patients have a hard time knowing if their doctor is going to do a good job for a certain thing. So yeah, just trying to improve the quality of care across the board using some technology things, I think will be really important.
All right. Oh, one more question. All right.
So Dr. Gensheimer, piggybacking on that whole notion of artificial intelligence, and how do you see it helping in the medical community in general, but more specifically in cancer diagnosis and treatment?
Yeah, okay. Well, this is going to take about an hour, so it's great that you guys have that time. No.
You have 2 minutes.
Yeah, no, it's a topic I'm really excited about, but that is a tough one. Yeah. No, it's exciting. It's just hard to know where to start. Yeah, I think there are a lot of different ways. I mean, one that I'm interested in is interpretation of scans and this sort of thing. So we get these MRI scans that have an incredible amount of detail in them, and then we have people review them. We have the best radiologists here, by the way, so I'm not saying anything bad about the radiologists at Stanford. They're amazing, and a big benefit to coming here for treatment is that you have them looking at your scans and looking at all the details that other radiologists might miss. But I am sure that computers will be able to look at all the different scans together, look at the pathology slides under the microscope, and detect nuances that we're just currently missing about whether the cancer is breaking outside of a lymph node or whether it has a more aggressive pattern under the microscope, this kind of thing. So I think just interpretation of the diagnostic tests and slides that we're already getting, I think in 10 years, that's going to be a part of routine practice and that'll be a big change. But it's changing year to year. I mean, a lot of these things are currently still in the research phase and they're on the cusp of going into the clinic. It's really exciting.
Great. Well, we are going to wrap up now because we are at time and we have people who we need to let go. So I hope we have met our goals today in terms of supporting quality of life for both our survivors and caregivers. We provided you with some high-quality educational material, facilitated connection, which I think was a big theme today, and then highlighted some of the services available. So I want to thank all of you for being here today. Please fill out the feedback forms. We do take those very seriously for planning next year. And have a safe travel home. Thank you.